Hi everyone, my name is Rebecca Mann. This presentation takes an in-depth look at reducing the risk of surgical site infections in the operating room. In surgery, there are certain parameters in which the environment must be at in order to be able to operate safely. Some of these parameters include temperature, humidity, air pressurization, and air exchanges that must be conducted and maintained around the clock. Specifically, the study takes a look at the efficacy of plasma air purifiers when implemented in the operating room and their effect on infection rates in orthopedic surgeries. The thought behind this is that the air purifier will filter out contaminants and microbacteria in the air and potentially reduce the risk of patients getting a surgical site infection. The content in this presentation includes information about the article and the study, including characteristics of the study, the outcome of the study, and how those outcomes came to be. These results will then be related to how practice is influenced today, if at all. The title of my chosen article is Effective Plasma Air Purifiers on Infection Rates in Orthopedic Surgery. This article was published on March 25th, 2025, and it was located at PubMed, which is an online database of medical articles that is maintained by the United States National Library of Medicine and the National Institute of Health. There are 12 authors of this article with varying backgrounds and credentials. It's important to note that this study was conducted in Sweden, and with that being said, I will try my best to pronounce everyone's name and clinical affiliation properly to the best of my ability. First is Anders Persson, who is a Swedish researcher and radiologist. Issam Atroshi is an adjunct professor and supervisor of orthopedic research at Lund University. Thomas Teisowitz is an orthopedic surgeon at Hässleholm Hospital. Niels P. Haler is an orthopedic surgery researcher at the Department of Surgical Sciences at Uppsala University. Stergios Lazarinis is a researcher at Uppsala University. Thomas Eisler is a researcher at the Department of Clinical Sciences associated with Danderyd Hospital. Harold Brismar is a researcher associated with the Department of Clinical Sciences at Karolinska Institute. Sebastian Mucha is an adjunct professor of orthopedics at Umeå University. Perwan Kernell is an orthopedic surgeon associated with Capio Orthopedic Center in Sweden. Mazrin Mohadis is an associate professor of orthopedics at the Sahlgrenska Hospital in Sweden. Olaf Skoldenberg is a professor of orthopedics at the Department of Clinical Sciences associated with Danderyd Hospital. And lastly is Max Gordon, who is an orthopedic professor and researcher at the Karolinska Institute. I was unsure of what the Karolinska Institute actually is, so I looked it up, and it's just a medical school that is located in Sweden. This article can be located in a few places. The article was published in the New England Journal of Medicine initially. It was also published in the PubMed online database, as mentioned earlier, where I retrieved it. Lastly, a discussion about the article and its results can be found on Medical Dialogue, which is a medical and health news platform website. Here you can find a link to locate the articles on each website. The type of evidence-based practice source for this study is identified as a randomized control trial. This study measures and evaluates the efficacy of interventions, and in this case, the intervention is the air purification system. In a randomized control trial, there is no bias, and it's considered a level 1 source, the highest source possible when identifying evidence-based research. The study is completely randomized, and there is no screening process for participants. Injury, procedure, pre-existing conditions, or overall condition of health are not considered while selecting participants. This study is thought to emulate the general population and does not exclude any participants in order to gain insight on the benefits of the intervention, if any. The population for this study includes 40,547 people undergoing orthopedic surgery. Of those participants, 19,869 were in the intervention group, which implemented the air purifiers. In contrast, 20,678 participants were in the control group, where the air filter was present but not turned on intraoperatively. The intervention in this situation is considered to be the implementation of the plasma air purifier during surgery. In order to compare results, the control group air filters were available but not turned on for the outcome. Surgical site infection rates in the intervention group was at 9.2% versus 9.4% in the control group. The results were close enough to say that there was no definitive difference in outcome or reduction of surgical site infections. The time frame for this study includes the 12 weeks after surgery. The question being addressed in the study is, does implementing the use of a plasma air purifier intraoperatively during orthopedic surgery reduce the risk of airborne contaminants and therefore reduce the risk of surgical site infections for patients? The study's purpose is to determine whether implementing the air purifier during surgery will reduce the occurrence of surgical site infections. The design of the study looks at the comparison of patient outcomes with versus without an air purification system during surgery. The population size in the study was over 40,000 participants. The setting was in Sweden. Data was collected over the 12 weeks of postoperative time for participants and then analyzed according to the occurrence of surgical site infections. The results showed that the plasma air purifier had little to no impact on patient outcome and the incidence of surgical site infections. This will not change current practice. However, it is meant to be informative for organizations who are seeking different avenues to control infection rates. The study was conclusive in answering the initial hypothesis of whether filtration of airborne contaminants contributes to preventing surgical site infections, and that was proven to be ineffective. The information from this study can be shared with other medical professionals in many ways. This includes medical journals, seminars, meetings, and online medical databases. From there, organizations have the ability to access the data and share among colleagues to incorporate into clinical decision-making processes and to make any adjustments to current practices. While this study showed no improvement in the reduction of surgical site infections, other potential uses for the results of the study include the following. It allows for prevention of organizations wasting money on air purification systems that are unnecessary and prevents organizations from spending a lot of money on medical-grade equipment such as this. It also diffuses the idea that an air purification system may be beneficial to patients and in reduction of surgical site infections. It provides guidance and encourages the exploration of other avenues in identifying other forms of surgical site infection prevention. Interprofessional uses of this study includes sharing the study results with the infection control department to rule out the implementation of air purification devices and its efficacy. It also facilitates the collaboration with other operating room team members. This includes pharmacy, surgeons, nurses, surgical techs, anesthesia providers, and anyone else who are all invested in patient safety and infection prevention.